The best thing about embolization, and this is compared to other surgeries, is that they can be completely awake. They can walk out of the procedure room. They typically go home an hour after the procedure. My dad had this procedure. I'm going to have this procedure pretty soon, I think. But the success rate in actually improving someone's lower urinary tract symptoms, assuming that they have moderate to severe symptoms, is about 80–85%. And when you're 60, 70 years old, you don't really need it anymore. And so we would love to remove the entire prostate, but obviously a prostatectomy is a major procedure, which is why we have all these minimally invasive procedures for prostate.
Welcome back to the Rena Malik, MD podcast, your source for evidence-based information about your sexual health and more. I'm Dr. Rena Malik, urologist and pelvic surgeon. Today, our guest is Dr. Aaron Fischman. He's professor of interventional radiology at Icahn School of Medicine at Mount Sinai in New York. And he is an expert in prostate artery embolization. He's authored hundreds of peer-reviewed publications about a variety of different things in interventional radiology and currently has pioneered a new technique to block blood flow to the prostate to help men with BPH. In today's podcast, we go over everything about this procedure, what you can expect, how well it works, what sort of complications there are, and should you worry about radiation when you're getting a procedure like this. I've been asked about prostate artery embolization for years on my YouTube channel, so I thought it only fitting for me to bring you the expert to answer all your questions. Now, before we get into the podcast, make sure if you are not subscribed to the channel or wherever you're listening to this, please do so. It is a zero-cost way to support, and I can see that out of all the people who watch and listen, only 20% of you subscribe. Guys, it's completely free and helps me create more content each and every week. So let's get to it. All right, Dr. Fischman, thank you so much for joining us today.
Thanks so much for having me.
It is truly an honor. We obviously have academics on the podcast, but you've written like over 350 publications, so many citations, like just amazing amount of work in radiology. And so I'm really excited. And you're one of the pioneers in prostate artery embolization. So I think it's going to be such a great conversation.
Yeah, absolutely. Thanks for having me. This is great.
Of course. Yeah. So just for our audience, let's give a little background. What is an artery embolization?
You know, the first thing I wanted to say was interventional radiology is not something that most people even know what it is.
Yeah.
Interventional radiology is really image-guided surgery.
Mm-hmm.
So we use small catheters, small wires. We guide them through the body using X-ray. And once we find the target of what we're working on, we can actually deliver chemotherapy. We can cut off blood flow to different organs. We can treat cancer. We can treat women with fibroids. We can do thrombectomies or taking clots out of people's legs or arteries and even in their brain. We have a whole pathway now where we can do neurointerventional radiology. So it's an amazing specialty.
It's so cool. And we certainly share a lot of patients in urology and interventional radiology for different types of interventions on kidney tumors and now with enlarged prostate, BPH, and obviously getting access to the urinary tract in a variety of different ways. So we work closely with interventional radiology. We don't always see you guys, but we certainly share a lot of patients.
Yeah, absolutely. The majority of my practice when I first started was not urology. And like you said, I do a lot of different urologic interventions, and that's probably 80–90% of my practice now. Yeah. Kidney tumors, men with varicoceles, as you know, it's a fertility issue for some men. Obviously, prostate embolization, which is what we're going to talk about today. And lots of other things too, and kidney tumors, things like that. So
yeah, and it's great. It's a wonderful addition to many treatment options, and for the right patient, they can be really great. So one of the things we're going to talk about today is prostate artery embolization, which is a new, not necessarily new, but more emerging treatment for enlarged prostate. Yeah. And so, what is an artery embolization?
So embolization is a procedure that we do all over the body. So embolization is basically cutting off blood flow to an organ or some sort of structure. So if somebody comes to the hospital, they're bleeding, we find the blood vessel that's bleeding, we block it. If you extrapolate that, you can actually treat liver tumors doing this exact same thing. You cut off the blood flow to the tumor. Many years ago in the mid-90s, we developed a procedure called uterine artery embolization, which is basically cutting off blood flow to women with fibroids in their uterus. And you can actually kill the fibroid without damaging the uterus by blocking the blood flow to that organ. And then about 15 years ago, we extrapolated that even further to treat men with large prostates. And so essentially what we try to do is we put a small catheter inside the blood vessel, and we can go in through the artery in the wrist, the artery in the groin, and we can use X-ray and find the pathway where those arteries connect and go all the way into the prostate artery. Most men have two arteries. We find both of them and we block them on purpose. And so the same way that you would lose blood flow to any other organ, you can purposefully cut off the blood flow to that structure.
So you said you're sort of aware that you're entering, but walk us through what a man goes through during the procedure. Are they awake? Are they asleep? What's their sort of sensation like afterwards? What are they expected to do after procedure?
The best thing about embolization, and this is compared to other surgeries, is that they can be completely awake. They can walk out of the procedure room. They typically go home an hour after the procedure. So what you experience is very simple. We usually numb up the skin. I always use the artery in the wrist. The artery in the wrist is much more superficial. It's very easy to see. We basically put an IV, similar to an IV, right into the artery. So that's not very painful. And then the entire procedure takes about an hour, maybe a little less, depending on the case. And you can be awake or you can be slightly sedated. Most people elect to have a little bit of sedation. And so we use very light sedation for this. So you can have conversations with the patients. I talk. We listen to music. It's actually very relaxing for patients if they're a little bit sedated, but they can be completely awake.
Yeah, that's so cool.
Yeah.
I think the interesting thing is not a lot of people do it using the artery in the wrist. Is that right?
It is right. And, one of the things that early on in my career that I spent a lot of time researching was how to take these procedures that we do through the artery in the groin and move them to the artery in the wrist. And we had known for many years, particularly in cardiology, cardiologists started doing this many years ago. But we didn't really do it that much in interventional radiology. So we really developed a completely different way of doing these procedures. And the radial artery in the wrist, which is the one we use for prostate embolization, is so easy to access. It's so comfortable for patients. The risk that you have any bleeding afterwards is much, much lower. So in terms of patient comfort and the experience, and I've always wanted to focus on improving the patient experience for these things.
Yeah.
This is an amazing advancement.
Yeah, the patient experience is so important. So I remember I had a hip MRI once and I had an arthrogram. So they had to inject some dye into the hip. And it was the weirdest experience. Like I walked in, they're like, oh, the radiologist is going to come inject some dye. He barely said 2 words for me, injected the dye and walked out the room. And I was like, that was really weird. Like, I was like, I mean, clearly, people are proceduralists and they're very focused on doing the procedure. And we're all guilty of that at times. But I was like, this is such a weird experience,
It is weird.
but that's, hopefully not the norm. But, we all go through it. Me too, being a doctor. Like, I didn't tell them I'm a doctor. I didn't say anything. I just acted like a normal person. Well,
doctors are the worst patients, right?
I know. I try not to tell people I'm a doctor. So, yeah. And then in terms of like going through the wrist, it's a little bit of a longer trajectory.
Yeah.
Right?
That's one of the challenges. And when we first started doing a lot of these things, we were really only presented with equipment that was sized appropriately for going through the artery in the groin. And now it seems like it's very close to the prostate, right, in the groin, but you do have to navigate through all the blood vessels and go around. And so it's not as far, but it is different. And so when you use the artery in the wrist, you need to have specialized equipment for that. And so it's really important that you understand that.
Yeah. That's that. And then what about people who are taking anticoagulant medications like aspirin or apixaban or any sort of medication that thins their blood?
We actually see a lot of patients with this. A lot of patients take blood thinners. It's very common. A lot of people take aspirin, like you said. With radial artery access in the artery in the wrist, since the bleeding risk is so low, we don't even stop those medications. So you can be on full anticoagulation. It's not an issue at all.
Great. What about through the groin? Can you still do?
You can. We have different devices that we use to sort of put a little plug in the artery when we're done. So we can use that in somebody that has that's on a blood thinner. But it's generally, most people would stop it for that. So one of the advantages of doing it through the artery in the wrist is that you don't have to stop any of those medications. And obviously, if you compare that to all the other interventions that we do for BPH that urologists do, like yourself, it's much different because I would imagine there's not many procedures that you would do with people.
We can do some with aspirin, but usually not anything more than that.
Right.
Not any sort of apixaban or Coumadin. People still use that. In terms of the embolization itself, what are the materials that you're using? What is going in someone's body? Yeah,
that's a great question. The best way to sort of think about this is we started out doing this procedure with something called particles, and they're very small calibrated microspheres. They're typically made of gelatin. Gelatin-like substance. There's different sizes. You can have some that are 100 microns. You can have some that are 800 microns. And so we usually use some of the smaller sizes around 100 to 300 microns. And we inject those particles, which are not really visible under X-ray. So what we have to do is we have to mix them with some dye. And we usually mix them with regular X-ray dye. And as we inject them, they go into the prostate artery and clog the artery. One of the things that I've been working on for the last 3-4 years is thinking about a better way to do that. And so one of the things, and this might sound crazy, but one of the things that we've been working on is not using particles. And there's some technical reasons why we think that they might not work as well, and using something called cyanoacrylate, or basically crazy glue, with medical grade crazy glue. And the glue will actually go into these blood vessels and seal them permanently. The reason that we think that might be a better way to do it is because if you look at some of the data, and I'm sure you've seen some of it, there are some men that get recurrent symptoms after they've had a great successful procedure where they feel much, much better. And so the statistics are really interesting. Around 5 years, about 20% of patients can get some recurrent symptoms. And we think that's because the blood vessels tend to reopen. So you imagine putting these little tiny balls inside the blood vessel, and they stack up and they clog the blood vessel. Eventually, the body will pull those particles outside the blood vessel and sort of digest them in a way. One of the things that happens when you use a glue-like substance is it completely damages the blood vessel, so it doesn't have the ability to grow back. And that, I think, gives us better outcomes. And that's one of the things we're working on right now.
You've mentioned a few different technical things, right? Like going through the wrist, using a different material. Are there certain things that lead to, I mean, we think that maybe this glue acrylate actually leads to better outcomes, but are there things that have been proven at this point in time that are better, that if someone's meeting a radiologist and they're saying, hey, I want this procedure, they should look for?
There's lots of different things that we talk about. One is patient comfort, like we mentioned, with the wrist artery. The other things that we use very advanced equipment, imaging equipment. And so we have the ability now to do essentially a CAT scan in the room. So we find the artery and we say, we're not so sure where that artery is going. If we're unsure, we can actually do a CAT scan and it'll show us exactly what we're injecting the dye into. It'll show us the entire anatomy of the prostate and allows us to be very accurate with our treatment. There's a lot of technical things that we talk about with this procedure. It's just so interesting because everybody has different anatomy. There's all different types of variations. And so you need to be able to visualize the anatomy exceedingly well. So we have new equipment now, which lowers our radiation dose. So we can actually see all these blood vessels with super low doses. And so the risk of having any sort of high radiation procedure is extremely low. It's not really even an issue anymore.
Yeah, so I read a paper where it said that the radiation dose is somewhere between 12 and 17 millisieverts. So for the audience, what does that equate to? What sort of radiation exposure?
Well, you go on a transatlantic flight where you go from New York to California, and you're going to get a decent amount of radiation. So I sort of think about it like you compare it to a CAT scan, and a lot of men have had CAT scans for different reasons, and so we can do it with basically less than the amount that you would get from a CAT scan. Now, there are some people that don't have a lot of experience doing this procedure, so it could take longer. And so one of the things I would advise men to think about, and this is something that urologists have talked about for a while too, is there's a lot of people out there that might do this procedure once in a while.
Right.
This is a demanding technical procedure, and so it really requires somebody to focus on it and to spend a lot of time understanding how to do it really well. So there are people that do this all the time, and those are the physicians that people should seek out.
Yeah,
sure.
Absolutely. I think because you said interventional radiologists can do a lot of things. And so they could spend their time doing multiple different anatomical areas. And it becomes hard to be really technical. And as you've said, the prostate artery is not always very easily found and defined.
Yeah, it's tricky. Yeah. It's a fun procedure to do. And when you get really good at it, you can do it very quickly and very safely. And that's really the most important thing. We want to do this procedure safely without any issue. And the big advantage, in most of my patients could probably tell you this, they get dramatic responses most of the time with very little invasiveness. And that's really critical for these patients.
Yeah. And tell me, in terms of when a patient decides, I tend to refer patients for prostate artery embolization. So when a patient sees me, I don't think they're great based on what they want and they desire out of this procedure, and they want a minimally invasive option, I'll send them to interventional radiology. But in terms of other people, are you getting referred from primary care doctors? Are you seeing patients yourself? How does that work?
It's a great question. It's all of that. I get lots of referrals from urologists, but I also get patients that will just go on Google and say, hey, I found this procedure. I know that you do this. When can I see you? And I actually have a very hands-on practice. I see all the patients ahead of time in my office. We do the full evaluation. We do CAT scans. We do uroflow in the office where we measure their stream, very similar to what you guys would do. We do ultrasounds, measure their post-void urine volume after they pee. We do all sorts of blood work. We measure PSA levels, all the things that are critical in evaluating a BPH patient. I don't perform cystoscopy, but most men wouldn't ever need a cystoscopy or anything going into their penis before this procedure.
Yeah.
So the entire evaluation is completely non-invasive.
Yeah. So I would say that's good, because I worry that sometimes if you're going straight to a radiologist who doesn't know that, right, doesn't know the evaluation, which they should, or doesn't do a full evaluation, we want to make sure that there is evidence of obstruction based on some sort of imaging or cystoscopy, and that they have a flow that's decreased with the uroflow, and that they're bothered by their symptoms, right? Those are sort of the big things. And their PSA is something we test generally to make sure there's no concerns for prostate cancer.
Right. And we even screen for bladder cancer on imaging. We screen for prostate cancer many times with MRI if necessary. And so we've detected all sorts of things, even in the workup of these patients, that it may not be related to BPH in their prostate.
Right. So I think for anyone who's listening, it's really important that you're getting that workup, because urinary symptoms can be vague. You can have a weak stream, you can have dribbling after you urinate, you can have a stream that stops and starts, or you might have to wait a little bit. And sometimes you might have, waking up a lot at night, or gotta go. And while these symptoms are often BPH, there's sometimes other things, as you've alluded to. And so it's really important to get evaluated, because we don't want to miss those other things. And when you don't get a proper evaluation prior, it's more likely that you're going to have a not a successful outcome, because there might be something you've missed. That's
absolutely true. I would caution patients that go to somebody that wouldn't perform any evaluation ahead of time. Right. It's really critical to do it. And I don't rely on a urologist to tell me whether a patient's a good candidate or not. I work very closely with them, but I do my own evaluations. And if I don't think they're a good candidate, I'll very frankly tell them that. I'll say, you need to think about some other options. There's so many options for BPH. Yeah. This is one of them. Right. I think this is a great option. My dad had this procedure. I'm going to have this procedure pretty soon, I think. But it's really something that you have to have a full evaluation. It's critical. So let's talk about success rates. What are the success rates with this procedure? Yeah, so success is very interesting. It depends on what the patient's initial presentation is. So you described all these lower urinary tract symptoms: peeing in the middle of the night, peeing frequently. I see people, I even see Uber drivers, pulling over on the side of the road. I want to give them my card because I know that they can't go an hour without having to stop and pee. But the success rate in actually improving someone's lower urinary tract symptoms, assuming that they have moderate to severe symptoms, is about 80–85%. Mm-hmm. Not everybody responds to this procedure. And we have some idea of who will respond, but we don't know completely. And so this is the case with any surgical intervention. Mm-hmm. You don't know if somebody's going to respond until you do it. Now, there's lots of things that can help us predict. Men that have larger prostates are typically better candidates. Men who have normal bladder function, obviously those are better candidates. It's very challenging to treat patients that have bladder dysfunction because, as you know, once the bladder becomes weakened, it's almost impossible to get it back to normal. It's sort of a big problem that I see in my practice because men wait until they're 80, 85, and their bladder is just completely different than it was when they were 60. And so they don't have the best response. And so that's one of the critical things that we have to evaluate. But 85% of the patients that we treat typically get a dramatic response, but that's not 100%. So there's no procedure that we do for BPH that's 100%, as you know. Exactly. Yeah. And if someone tells you 100%, walk out the door because they're not telling you the accurate truth. But I will say you brought up a really good point. And I think that you can never be 100% sure that someone's bladder is working. So you do a uroflow and they have a flow that's weak. Now that could be because they're blocked from their prostate. And we know that when it's enlarged, that's more likely the case. However, sometimes we'll see guys who've had an enlarged prostate for years and their bladder stops working. Or there's other causes like neurologic causes. And I think that's really important to bring up because there is, a number of patients that won't respond to a prostate procedure, anyone, right? Because they haven't identified that. So there are some risk factors, and that's where we can do other testing, like urodynamic testing. But ultimately, I think it's really important to realize it's not always the prostate. Now, it's very commonly the prostate, but it's not always the prostate. Yeah. There's actually two other indications that we treat patients. The second would be somebody who has blood in their urine. That's very common, and this procedure works great. It's very similar, 85% for blood in the urine. Yeah. But then there's also people who present with acute urinary retention, where they come in and they're miserable because someone just put a catheter in because they couldn't pee, and they're walking around with a Foley catheter. That's very disheartening for a lot of men, particularly men that have an active sex life. It's very challenging, obviously, when you have a catheter. And so those men are typically in a little bit more of a dire situation. And the success rate in actually removing catheters in people after embolization is about 80% as well.
Is that in people who've had a catheter for a certain period of time, like 7 days, 2 weeks,
Well,
3 months?
It's sort of all comers when you
Yeah.
think about it. But obviously, I've had patients that come in, they've had a catheter for years. Their bladder's sleeping, obviously.
Yeah.
And so that's going to be a challenging case because you have to eventually get the bladder to wake up. And so there's things that we can do for that. But there are men who just intermittently catheterize themselves, which sometimes is a better option for these patients if they can do it, because it does give their bladder some time to function normally. But in general, bladder dysfunction is sort of the big enemy of any transurethral or embolization procedure.
Absolutely.
Yeah.
I hope in the future we have a better way. I think urodynamics is a good test. It's basically, for those listening, it's a test where we put a catheter in the bladder, a catheter in the rectum. We fill the bladder with fluid. They have pressure monitors on those catheters that we can then see when you're peeing or urinating how much pressure your bladder generates. And so that tells us when it's blocked, you're going to have a high pressure, right? And when it's working normally, you're going to have a normal pressure. And when it's not working, it's not going to have any pressure except for what your belly makes, right? When you bear down. And so that's a helpful test. It's a very good test, but it's more invasive. And so hopefully there will be better testing in the future.
What I often tell patients is we could do a urodynamics if we're not sure. But the reality is the urodynamics is more invasive than the actual treatment. And so that becomes a little bit of a challenge for some patients.
Yeah. But let's talk about risks. You mentioned sex life. So I think a lot of people, this is where a lot of new innovation in the BPH space is. A lot of people don't want to deal with side effects of prostate procedures like retrograde ejaculation, potentially risks of erectile dysfunction. So what are the risks with prostate artery embolization?
Well, no procedures without risk. Anytime you put a catheter inside the blood vessel, there's always a risk that you could create some sort of damage to that blood vessel. This is exceedingly rare. The biggest risk that people talk about with embolization is what we call non-target embolization, where when you embolize the prostate, it's a big network. All the arteries connect in the pelvis. And so the artery that goes to the prostate will also go to, in some cases, to the penis or the bladder or the rectum. There's shared vessels. And so we really need to focus closely on those connections and try to understand them. Despite all of that, you can still get some of this material, whether it's the particles that we talked about or the type of glue that we use, into these other organs. Most of the time, that's without any symptom. But if it's a significant amount, it can cause symptoms. That can be somewhat disheartening for the patient. If we have a complication, we get through it. Most of these complications, pretty much all of them will heal. And so I've never seen any long-term sequela with any of that. One of the things that we talk about with non-target embolization is, well, what if it goes to my penis? Am I going to lose my erections? Am I going to have any issues like that? We just haven't seen that clinically. It's just not something that comes up. There are a small number of patients, and this is exceedingly rare, but if you do enough of these procedures, you do see some of these things. One of the things that people can talk about is skin ulceration on the penis. Exceedingly rare. We're talking about much less than 1%. And it's disheartening when you get a little ulcer on your penis. It sort of looks like an STD, but it gets better over time. It heals. And so these are things that we can get patients through if it happens. But when you compare the risks of this with any of the sexual side effects from the other minimally invasive treatments, the risk to a man's ejaculation or sexual desire or orgasm is basically none.
You know, I saw some papers where there was some change in ejaculatory volume after prostate artery embolization.
Yeah, so some men will describe what you just mentioned. They'll say, well, my ejaculate used to be much higher than it is now, and I feel like it's just a different amount. It makes sense, right? Because if you think about what you're doing with embolization is the best analogy I like to use is that, let's say you have a big round sponge that's filled with water, right? It's boggy, it's heavy. That's what a prostate that's enlarged feels like in your pelvis. If you do an embolization, what you're doing is you're turning off the faucet and you're squeezing all that water out of the prostate. The prostate's still there. The sponge is still physically there, but it's not as heavy. It's not as boggy. When you squeeze all of that fluid out of the prostate, these men start to feel so much better. The way that we sort of think about embolization is we want to shrink the prostate. And so when you shrink the tissue, and as you know, the prostate makes a lot of the seminal fluid, you're going to decrease that production to some degree. But not everybody experiences that. Most people don't really notice any difference in their ejaculate volume.
Yeah. The reason a lot of these newer procedures for BPH have arose, like prostate urethral lift and water vapor therapy, were because to reduce sort of these ejaculatory concerns. The erectile dysfunction concern always was interesting to me because we're not getting anywhere near those nerves when we do standard standard, let's say, transurethral resection of the prostate, we're not getting near the capsule. So it's really unlikely that you're going to damage any of those nerves. And we know that men start having more erectile dysfunction as they age. And so it's very possible that someone may develop ED after they have a procedure. But certainly we do see that concern with ejaculatory issues because many of the procedures we offer cause retrograde ejaculation.
Yeah, retrograde ejaculation is a completely different thing. We see that all the time with the medications that men take. Tamsulosin is Rapaflo is another one that men experience retrograde ejaculation. It's very common. With TERP, it's actually more common than not.
Yep.
With the procedures that you mentioned, like Resume or Urolift, it's much lower than that. But when you compare those retrograde ejaculation numbers to prostate embolization, it's close to zero. It's very rare that you see retrograde ejaculation. I've seen it a handful of times after embolization, and no one really understands why that occurs. It's different, but the risk of having any sort of ejaculatory issues is exceedingly low.
What about how long it takes, right? So we're talking about shrinking an organ. That's not going to happen immediately after you embolize an organ. So how long does it take for people to start seeing symptom relief?
It's a great question. So I usually say we're not going to be able to judge whether you responded at least for 6 weeks. You start to feel better around 2 weeks, but the prostate starts to shrink, and it shrinks over a period of months. We don't look at the size of the prostate until about 6 months, but we usually do a clinical follow-up where we talk about symptoms. We do their symptom scores. We check their flow, and that's around 6 weeks. And most people have a good clinical response by then. Some people have to wait a little bit longer, but usually by 6 weeks, and maybe even sooner in some people, they feel a lot better. Now, people that have catheters, we try to remove the catheter about 2 weeks after the procedure. If it doesn't work at 2 weeks, we do another trial, typically 4 weeks later.
So our radiologist will often prescribe some anticholinergic or medication to relax the bladder after a prostate artery embolization. Do people expect to have an increase in sort of worsening of symptoms during that first 2 weeks?
There's another analogy I like to use for this. If you have a surgical procedure, not an embolization, it sort of feels like you have an injury. It's the equivalent is like if you have an injury, it takes a little while to rehab it. Embolization is different. It's sort of like if you go to the gym and you have a really tough workout. So how long does it take to recover from that? Usually a few days. Most people have about a week of symptoms where they feel worse. And so all of their urinary symptoms get worse for about a week. The prostate gets a little angry after you cut off its blood supplies. You do have to be aware of that. So they get some pelvic pressure. They do feel like they have to pee a lot more frequently. Some people describe getting up even more frequently in the night, and it lasts about a week. And then they start to feel a lot better after that.
Yeah, I used to do the water vapor therapy procedure, the Resume, and I would tell my patients, you're going to hate me for about 2 weeks.
Yeah.
And then you're going to love me. But in the beginning, you're going to hate me.
You have to
it's
tell
going to be a lot
that.
worse.
No, I mean, some people do hate me, but I tell them, you're going to hate me for 2 weeks, maybe less, and then you're going to feel a lot better.
Yeah. And then what about, downtime after the procedure, return to sexual function? Are there any limitations?
There really aren't that many limitations. It's really what the patient wants to do. They'll get up, they'll walk out of the procedure room, they have a Band-Aid on their wrist, they go home. They feel those symptoms at home, but they can work. They can do all their normal activities. They can go to the gym. We usually ask them not to lift heavy weights for about 24 hours because of the puncture we put in the artery, but they can do whatever they want. They can go out with friends, but they're going to be peeing a lot. I mean, if they're playing golf, as an example, the next day, they're going to be peeing much more frequently than they would otherwise. But most of the men that I see are so in tune with their bodies that they understand that this is going to be, a short period of time where they have to just take it easy, but they can do whatever they want.
So I read this study that looked at readmission rates, and it was actually in New York. It looked at 30-day readmission rates, 90-day readmission rates after prostate artery embolization, a transurethral resection of the prostate, and a prostate urethral lift. And it was an interesting study because there wasn't that many prostate artery embolizations. So I'll be honest, there are limitations in the study, but it saw that the readmission rate was significantly higher after prostate artery embolization for symptoms like abdominal pain. Is that something that you see typically, or?
No, I think this gets back to what we were talking about before. It's about preparing the patient for these things. And if you tell somebody that they're going to walk out of the procedure room and feel like nothing happened, that's not really the case. Coming back to the hospital is almost unheard of. I mean, we manage all of these symptoms at home with medications, and almost all my patients have my cell phone. They call me and I text them and see how they're doing. And my nurse practitioners do the same thing. So it's all about preparing. If you know what you're about to get into, it's much easier. You just don't want to be surprised, the next day that you're peeing every 10 minutes,
you think something went wrong.
You think something went wrong, but it definitely didn't. It just means it's working.
So maybe those were just earlier doing these procedures earlier and not knowing what was sort of expected.
Yeah, I think that's right.
Okay.
Yeah.
And then what about long-term success? So you've alluded to that there is a higher reoperation rate, at least with the particulate matter. And there was a study back in, I think, 2017, so this was years ago. I think prostate artery embolization has sort of much more evolved since then that showed that there was a significantly higher reoperation rate compared to transurethral resection of the prostate at 5 years. And so that's a bit concerning. Now, it may be fine if someone's like, I want to do this now, I'm active, I'm busy, I don't have the time to have surgery. But what are you seeing in terms of reoperation rates?
Great question. I think when you look at the data, and I trust the data from Brazil, Dr. Carnevale published this 10-year data a few years ago, and he was one of the first to do this procedure. I trained with him many years ago, and so I know how well he does this, and I actually trust his data. And the data is actually very interesting. It's about 20% recurrent symptoms at around 5-6 years. It's not that dissimilar to something like UroLift or something else transurethral, but 20% recurrence is not ideal, right? We want to do better than that. And that's really the impetus for us trying these newer embolic materials like something like glue, because we do think, and it's still a little early to tell because we've only been doing this for about 4 years, that the recurrence rate should be less. And the scientific reason for that is the artery has become much more damaged, which is what we want. We don't want the prostate to stay alive. We don't want the arteries to reopen. And so that's really the reason why we see that, I think.
Does the prostate form collaterals then?
Yeah, it does. Yeah, it does. Yeah. We see there's blood vessels inside the prostate and there's blood vessels that are sort of outside the prostate. And so if you can't get the material into the prostate completely, you can imagine that the prostate will find new blood supply. It's actually very, very easy for it to do because there's so many blood vessels in the pelvis. And so one of the challenges is we do these angiograms or these pictures of the blood vessels. We look for all those collaterals. We can see them. And so you find 2 arteries that go to the prostate. It's very easy to find the 2 main arteries. But the real challenge is to find these collaterals. And so one of the things that we think helps as well is to find them during the index procedure. Mm-hmm. And so you don't have to worry about those reperfusing the prostate. So we do look for those when we do these.
But you don't embolize them at this point in time?
If we see them and they're big enough, we do. But we know based on previous experience where they typically come off of. And so we can go and look for that.
Yeah. I think a lot of people wonder, okay, if I embolize my prostate, am I going to do any harm? Are they going to harm anything by getting rid of their prostatic, they're shrinking their prostate?
No, I don't think so. I mean, the prostate is sort of it's a fertility organ. And when you're 60, 70 years old, you don't really need it anymore. And so we would love to remove the entire prostate, but obviously a prostatectomy is a major procedure, which is why we have all these minimally invasive procedures for prostate. So removing it would be great. If we could remove everybody's prostate, I'm sure we would love to do that. It's just not feasible.
Maybe someday.
Yeah, right.
Maybe someday. There was a paper that looked at complications. And again, I don't remember the year of this paper, but it said that there was basically grade 1 and grade 2 complications, but they're usually minor. Maybe you need a medication. Maybe you need something additional. Range from anywhere from 1% to 67%. Yeah. So what do you think? I think for people just to understand, what are the things that they will really probably deal with?
Yeah, there's expected side effects and there's complications. Complications are exceedingly rare. Mm-hmm. The side effects are real, and we talked about some of them, but the biggest one is really just frequency, urgency, burning, and worsened nocturia or peeing at night. That's almost everybody gets one of those symptoms.
Yeah.
That's not a complication because we know it's going to go away after a few days.
Yeah. And the dysuria, the pain with urination, that can be really scary for people. But I think if they know it's coming,
we treat it with medication. There's very common medications that we use. They don't work amazingly well, but it's just time.
What about blood in the ejaculate?
Some people get that. It's not super common, but the blood supply to the seminal vesicle is actually sometimes shared with the prostate artery. And so we many times are embolizing the seminal vesicles too. So sometimes the patients will get some blood in their semen for a little bit. I usually tell patients to wait about a week before they have sex or to do any sort of masturbation or anything like that. Not everybody listens to me, but it's okay to have any sort of sexual encounter after. It might be, you might not be in the best physical condition to do it, but it's okay. You can do it.
Yeah. I think the other thing about hematospermia or blood in the semen is that people don't realize it can last a long time. It really just depends on how frequently you ejaculate. So for some people, it can take a whole month and they are still seeing blood in their semen. Right. And so I think just not to be alarmed that it's usually, of course, if you had a procedure, it's from that procedure. Yeah. But even as a urologist, I tell patients most times, it's a benign cause. And as long as it goes away, nothing to really worry about.
Yeah. And hematospermia is something that we've we treat rarely as the main reason why we do embolization. There's some people that do really well with embolization just specifically for that symptom. So we sometimes do that too.
So in terms of risks of radiation, let's just talk about generally, because I think there's a lot of misconceptions in society about radiation exposure, whether it's from a procedure like this, a mammogram, a CT scan. What are the true risks? Like, what should people be looking for in terms of their own health? Like, what is too much?
Well, there's principles in radiology. We use something called ALARA, which is as low as reasonably achievable. That's generally the policy that we follow with all sort of radiation exposure. So what that means is you want to minimize the radiation dose that you're using. That involves not using radiation unless you need it. It involves spending less time on the fluoroscopy pedal or the X-ray pedal. And it also means using equipment that's good. There's a lot of equipment that people used to use years ago that had a much higher radiation dose. The machines that we use now are so low that the radiation exposure is super low. And like I said, it's similar to what you would get from a CAT scan. So, and many times less. So it's really not a lot of radiation. And I think, one of the problems with this procedure early on is it would take operators a long time to do it because they didn't understand the anatomy as well back then. And so now we can do it much faster than we used to. But there are some people that do it rarely and their radiation doses could be a little bit higher. So what I would say to men that are thinking about this is to really do their research and find people that have a lot of experience doing it. They can do it much faster and with much less radiation dose.
And who do you think is the ideal candidate for this procedure?
So the ideal candidate is probably somebody who has a good size prostate. So what's good size? We say above 60, but you can treat people with smaller prostates too. But I see a lot of patients where their prostate's 150, 200, totally fine. There are limitations with some of the other procedures with larger prostates, but there really is no size limitation with this. People that are, like you said, have a normal bladder function, and we try to determine that ahead of time. People who have moderate to severe symptoms. If somebody has mild symptoms, they're not going to get that much better. We like to say people who have failed medication, but there's lots of men that just don't want to take medication. So it's not like that's a requirement or anything. But really, large prostates, people that have good vascularity in their tissue, so good arteries. You look at their CAT scan or their MRI, you can see that on those images if the blood vessels are good and robust that go to the prostate. And if you can find a good artery and embolize it, you can do really well.
So if you're looking at people who have, a lot of people fall in that 40 to 60 gram range, do you think they do less well with prostate artery embolization?
Lots of people have been looking at this, and I think a lot of it depends on the operator. The challenge with smaller prostates is the arteries are smaller and harder to find. There's also a challenge that you're not going to shrink the prostate as much if it's on the smaller side. So percentage-wise, you're not going to get as dramatic of a benefit. But the analogy where we squeeze that water out of the sponge, you don't necessarily have to reduce the volume to have symptom relief because you're relieving the obstruction by sort of getting rid of all of that dense fluid in the prostate. It's something that we look for too on the imaging to try to understand whether the arteries are big enough and robust enough. And so you can have a really small prostate, but a beautiful artery, and you'll do really well too. So
it's really sort of anatomically dependent on the arteries.
Yeah.
Okay. Looking ahead, what do you think is going to be the biggest change in terms of how people perceive prostate artery embolization?
I know that when I need a procedure for this, I'm going to have an embolization. All of my family members as well, I would recommend the same thing. And I think as we sort of move through the next couple of years, we know that as the male population is aging, pretty much everybody at some point. I mean, we know it's 80% of patients that are 80 years old are going to have some BPH symptoms. Most people are going to want something done. And when you're thinking about what you want to do about it and you want to do something a little bit more than medication, the decision to do a surgical procedure, I think, is a more difficult one. I think the decision to do this minimally invasive treatment is a little bit easier for men to wrap their head around. And I think it's dramatically increased over the next couple of years. There's no question about it.
Do you think there's enough radiologists performing it for that increase in demand?
I don't know if that's the case yet.
Yeah.
There are lots of people that do it. The growth in the last couple of years has been pretty exponential, but there's probably not enough. And one of the things that I focus on is training. I do a lot of training of my residents and even my medical students that come in to see how to do it. But ultimately, when we want to teach somebody how to do this, we want some sort of visual key. And so we do a lot of training courses where we record live videos and we have technical things that we talk about to other physicians. So you can see some of that stuff on my YouTube channel.
I think the challenge with interventional radiology is you guys do a lot, right? Like you talked about before. So having someone really focus in on the prostate, that's a big ask for something that's probably more challenging than some of the other procedures you guys perform.
Yeah, it's hard because not everybody wants to focus on it. Not everybody has an interest in it. I think the more people that do it and the more people that learn how to do it, I think become more comfortable with it. But when I first started, I didn't have this as my primary focus. It was lots of different things, like you said. But as I've advanced through my career, it's become something that I focused on. And I think it's really important to have intervention radiologists that are focused on it. And there are many. Mm-hmm. Is there enough to take care of all the men in the U.S.? I don't know that we have that yet.
Well, I'm not sure that everyone will, there's so much available, but we do need more if we want to utilize it more, I think. So in terms of finding an interventional radiologist who might be an expert in this, how do people go about doing that?
I would love to say that there's an easy answer to that question, but there's not. I know from my interactions with colleagues who does it and who does it well. Mm-hmm. So I'm always happy to refer people that live in different states to different people. But people have to just do their own research and ask questions, and they need to speak to their intervention radiologist and say, what's your experience with this? What kind of outcomes do you get? How do you do it? What technique do you use? Do you do radial access? Do you do femoral access? They should ask these questions. If you can't get in touch with a practice or an interventional radiologist that does it, even when you're trying to make an appointment, it may not be the right fit for you. Yeah. You have to really do your research. That's the key.
I do think expertise really matters because I think we certainly don't see that high of a success rate that you're quoting in our practice. But again, I think it just depends because that's radiology, that department that we work with takes care of a lot of different things.
Yeah. You do have to find somebody that does a high volume, but that's the case with a lot of surgical procedures, not just this.
Is there any other ongoing studies or things that you're excited about that you're working on right now?
Yeah, the biggest thing that I'm working on right now is really trying to advance the embolic choice that we're using. And I think, my big focus is on using a different type of embolic, something more of like a liquid. There's different liquids that we have available, and these are the things that I'm most interested in understanding because we really want to get those recurrence rates low. We want the side effects to be lower than they are potentially. And we just think that this procedure is good as it is, but it could be better. Yeah. And there's lots of things that we could do technically to make it better, but it does require a fair amount of effort and work to sort of move it forward. But this has been a big passion of mine for, the last decade or so.
Yeah. Are people doing that same sort of investigation in other embolizations, like you mentioned, fibroid or liver?
Yeah, sure. Well, fibroids we've been doing for many, many years. Yeah. The other procedures that we do that are pretty interesting, the biggest one I would say is embolization of the genicular arteries around the knee for patients with osteoarthritis. Wow. Osteoarthritis is many times an inflammatory condition where you do get increased blood flow to the structures around the knee, and so you could block those as well. We do that as well. There's patients that have hemorrhoids. We can embolize hemorrhoids now, all sorts of things like that. So there's lots of interest in all the musculoskeletal applications for embolization too.
That's so cool. I wonder why. I think that radiology is very much a referral dependent field, but I think that there's so much there that could be more direct to patient if it was, really done correctly. Because I think people deserve choices.
Yeah, for sure. I mean, this is the beauty of our specialty is that we provide minimally invasive treatments for very complex problems. The biggest problem that I see is that a lot of men and women don't know what we do. And so that's one of the reasons why I'm here, to sort of get the word out a little bit. Yeah.
No, I think it's important. Like I said, I think that you alluded to earlier, like some people wait till they're 80 and now their bladder's not functioning as well. And I tell my patients, I don't know if you're going to be that guy who at 80's bladder stops functioning. I've had guys where I do a transurethral resection on them and I'm like, they're definitely not going to do well, but they want it. And we talk about all the risks and benefits and, they don't want to do urodynamics and they do great. And so I can never guess just based on, obviously there's certain things that give us more caution and we'll try to do urodynamics, but ultimately you can't ever really tell who's going to be that guy who's starting to have symptoms in their 50s or 40s even, and which one of those bladders is going to stop working.
Right. You don't know.
And
I wish we knew.
I wish we knew because, it's not always the size of the prostate that matters, right? It's how it blocks. It depends on maybe your baseline bladder function. I mean, there's a lot of factors there. And I think that we have several societies for BPH, several in urology, but very few societies that focus on bladder function. I'm in one of them. And I think that we need to collaborate better and figure these things out. And I hope AI will help with that to some degree.
Yeah, we're working on some other things where we're trying to predict response based on imaging. Mm-hmm. There's the lobes of the prostate, the left and the right, but there's also the middle lobe. So there's different predictive factors with that. And we're also trying to understand, maybe using AI, if we can detect how vascular the gland is, which is sort of a unique property. We don't really think about that with other surgical procedures, but what we're trying to do is decrease the blood flow. And so if somebody has very little blood flow, they may not be as good of a candidate as somebody that has a lot of blood flow. And so could you determine the blood flow, the flow dynamics in the prostate ahead of the procedure?
Well, I would wonder about the collaterals. Like if they have more collaterals, they're probably not going to do as well. They may be very vascularized, right? But if they have a lot of collaterals that you can't embolize, then
one of the problems with collaterals is they're very hard to detect on CAT scan ahead of time. And so if you have some sense of what the collaterals would be, you might be able to know a little bit more going in. We have new CAT scanners now. They're called photon counting CTs. And so we're doing some preliminary work on trying to understand whether that could detect the collaterals ahead of time as well.
Yeah.
Yeah.
Very cool. So we end our podcast with 4 questions that we ask everybody. They can be about your profession or not. So what's something you know now in life that you wish you knew earlier?
The one thing I would say about at least my career is you sort of have to be open to trying new things, and you don't always get to the point that you want to get right away. And I think you have to be open-minded, and you have to be in the right place at the right time. And you don't necessarily know where you're going to end up in 5-10 years. And I was not surprised, but the way I got into this space of BPH was sort of very interesting. And I was sort of, many years ago, I was given the opportunity to go train down in Brazil, and I took that opportunity, and I learned how to do it, and I was able to build a practice just based on that. So one of the things that I would say is that you just have no idea what your life and what your career has in store for you.
Oh yeah. I completely relate to that. I think you asked me like how I started this podcast before we were talking, and you would have asked me 5 years ago, and I would have said, no way am I going to be doing a podcast or having, this big YouTube channel. And so I think it's just being open to things that come your way and like adapting. Yeah, absolutely. You have to adapt. And that's the hallmark of our specialty, is we have to evolve and adapt. It's just so rapidly changing. You have to be able to adapt to what's happening out there. Yeah, I think it's not there used to be this thought like, oh, the older doctors, they never want to change, but you just can't be that anymore because there's so much technology, there's so much evolving, and some of it's going to be great and some of it's not, right? Like there's going to be stuff that comes out that falls flat, but I think it's important to be able and willing to try new things, because you might find something that's like a diamond in the rough. Yeah, and I think from my perspective, PAE or embolization for prostate is probably one of the crowning achievements of our specialty in the last quarter century, I think. Wow, that's pretty impressive. Yeah, and I think that I'm really proud of that. That's cool. Yeah. What's a non-negotiable, something you have to do every day? I personally have to always put my youngest to bed every night. Oh, that's so great. Yeah. What's a life hack or a health hack you'd share? I try to be active, but I would say I've been focused a little bit more on certain supplements that I think have helped me energy wise, and so I have a little bit of a regimen, but people could. You want to share? Well, I mean, it's basic stuff that people know about. I take magnesium, I take CoQ10, I take multivitamins, I take fish oil, things like that I know that are going to give me some of the benefits that we want. Yeah. Okay, cool. And if you couldn't be an interventional radiologist, what would you be? Pickleball player. Yeah. Is that recent, or is that something you've always been into? No, I just got into it recently, but it's a fun sport. I like playing it. Yeah. It's fun. My kids are really into it. Yeah. Great. So you mentioned you have a YouTube channel. Where can people find you? So on X or I have they can reach out to me, direct message on YouTube. People can comment, or they can just go to my website and reach out. Usually what happens is my office will send me a message that someone's interested in embolization. And I always reach out to patients before they come in just to get a better sense of what they're dealing with before we meet in person. So people could always reach out via our websites. Awesome. Yeah. Great. Well, thank you so much. Thanks for having me. Awesome.